So I'm Dustin Seaton, Gifted and Talented Specialist at the Northwest Arkansas Education Cooperative. And thank you all for tuning in today for the presentation on SARS-CoV-2, COVID-19 signs and symptoms and spread. Today we have a special guest with Sanofi-Pasteur, Dr. Sushmita Yaganti. She's going to answer some of your questions today, but feel free to write any questions you have in the chats, and we'll make sure we get that at the end of today's presentation. So, Dr. Yaganti, I'm going to turn it over to you.
Hi. Hello, everybody. My name is Sushmita Yaganti, and I'm from the medical affairs team of Sanofi-Pasteur. I hope you all are doing well, you and your families, and manage to stay healthy during these challenging times. So I'm a family medicine physician by profession, and my role at Sanofi-Pasteur is basically talking to policymakers and have scientific discussions around immunization policy, vaccine-related science, and like public health and research developments. Like we are also working on COVID-19 vaccines currently. And a huge portion of my role is educating on different infectious diseases, vaccine-related topics, vaccine advocacy. So in today's talk, we will look into some of the data on SARS-CoV-2 and COVID-19. I know there is a lot of information available online, and sometimes it's overwhelming because there is new data every day coming up. So I will, so in my presentation initially, I'll give some basics virus and the disease states itself. And then we will go into, because CDC along with ACIP, it's having some updates every month. So they are meeting every month and having a virtual meeting where they talk about updates on COVID-19, the disease state, the epidemiology, and also the vaccine development. They want to just keep the public up to date in the development process. So some of the disclaimers, these disclaimers are pertaining to the disease because this is such a novel virus and disease. So the data, the new science, knowledge, and understanding, it's evolving every day. What I present today, it might change tomorrow. So, and currently we do not have any vaccine to protect against COVID-19. There are few medications that have been repurposed for use in severe and hospitalized cases. So non-pharmaceutical interventions, that's wearing a mask, social distancing, hand washing, these have been the most important response strategies to attempt to delay the spread of virus. So here we are not, it's not basically the treatment, but a prevention strategy to reduce the impact of the disease. So this is an electron microscopic picture of coronaviruses, the whole genera as such. So in Latin, corona means garland, crown, and really nice names, but I'm sure we don't feel so nice about this virus right now. So coming to the classification, so there are four main genera of coronaviruses. I am sure you might have heard coronaviruses all the time. Those are the human coronaviruses. So we have alpha, beta, gamma, and delta. So alpha and beta causes infections in humans, mammals, including humans, and gamma and delta, they cause infections in birds, anywhere from small birds to as big as ostrich. So most of these infections of coronaviruses, they have the common natural host is bats. So if you look at the table, the top row, where you see the four codes, those are the human coronaviruses, which I was talking about. And when we were, like all the pediatric respiratory diseases you see at school or at your home, your kids, your grandkids, they all, the common cold they get affected with, these are mostly the human coronaviruses. And these are very short-lived. They come, they have some symptoms, and they just, they just recover from that infection. But the bottom three are the main coronaviruses that were actually transmitted. So it's like transmitted from animals, and then you had human-to-human transmission. So first, talking about MERS, which was first, the first case reported was in Saudi Arabia in 2012. And because of the location, it was called as Middle Eastern Respiratory Syndrome. We still have this virus, and you see sporadic epidemics here and there, but is not as, so it is highly infectious, but you don't see as many cases as we see with COVID-19. Then the next one is SARS-CoV, or it's also called as SARS-CoV-1. The researchers called it CoV-1. So this was also reported in China in November 2002, and this caused the 2002 and 2003 pandemic. But luckily, we didn't have many cases in United States at that point of time. Maybe I think they were as low as 57, and the fatality rate was also very low. But this is not as infectious and communicable as COVID-2, but the people who got this virus, so the mortality rate was very high. And then the SARS-CoV-2, which is the most recent pandemic, and we will look into this in more details. So this picture shows you the spike protein. I'm sure you guys, everybody is talking about spike protein because most of the vaccines in development, pretty much all the vaccines in development are targeting this protein. And why? Because this is a protein that binds to the ACE2 receptors in your respiratory system. And then because of this viral binding, it gets engulfed into your, so it finds a way entry into your cells, and then it replicates inside your cells and causes infection. So right now, all the vaccines are targeting this spike protein because that's the only way they can neutralize it and prevent the COVID-19 infection. So how is this transmitted? So the major transmission mechanisms are respiratory droplets, aerosols, and fomites. So what is the difference between these three modes of transmission? So the major cause of the infection in the transmission mode is respiratory droplets. So here I want to highlight effects. So what is the difference between droplets and aerosols? If you look at droplets, these are usually bigger in size. So they are anywhere from 5 micron to 10 microns in size. And so they don't travel a longer distance. Maximum is like 6 feet, and that's the reason we ask everybody to have a 6 feet distance, so that even somebody coughs or sneezes, these droplets, they cannot travel beyond that. They will stay within the 6 feet distance. And this is highly infectious. These droplets are the major cause of infection. So now coming to the aerosols, aerosols are the smaller particles. They are less than 5 microns in size. So because they are lighter, they can travel up to meters. But how infectious these aerosols are, the data is not very clear. Like, what is the severity of the infection caused by the aerosols? Similar is the case with fomites.
What's your cell phone number?
R79.
If you, I would request you if you can mute yourself. Okay, thank you. So fomites, as like whenever somebody sneezes or coughs and they touch those surfaces, so what happens is the virus has the capability to survive on those surfaces for quite some time. But even as how infectious this mode of transmission is, it's not yet clear. So talking about the infectious and symptomatic periods, so the incubation period, the period in which the virus grows, is anywhere from 2 to 14 days, depending upon your immune response and the immune system of the person. And the mean is 5 days when you can see the symptoms coming up, and also the person is infectious during that period. So different, like asymptomatic infections, it's not yet clear, but we have seen some cases where asymptomatic patients have transmitted the infections to healthy population. So this transmission dynamics, this slide shows you how the transmission occurs and why currently the tracing is difficult because of the asymptomatic patients. So if you look at the red person, those are the symptomatic persons who have shown the signs and symptoms of COVID-19. So if you look at the first person, he got interacted with the first cluster where you see the family, and one person in that cluster got infected and shows the symptoms of COVID-19. And then this person interacted with the cluster on the top, and it was further transmitted to another person in the cluster. Interestingly, if you look at the lower flow, this first cluster interacted with two people who are not encircled, and none of them had any signs and symptoms of COVID-19. But these two people interacted with the new cluster, and surprisingly, there is one person who had signs and symptoms. So what this proves is that the asymptomatic people are also transmitting the infection, and that's the reason why you see one person infected in the new cluster. This table is very interesting. It just shows you where COVID-19 lies in the space of infectious disease. So on the x-axis, you see case fatality rate from low, medium to high. And on the y-axis, the vertical axis, you see the number of people infected by each infected person. So how many people, it's mostly the reproduction number. So if you look at measles, which is on the top, measles is a highly infectious disease with high mortality rate. So each measles person, if one kid has measles, he can transmit it to up to 12 to 15 other people. So it is that infectious, and even the mortality rate is very high, and followed by polio and smallpox in that range. And when you come to the lower infectious diseases like influenza, so each influenza person can transmit it to anywhere from 1 to 2 other people. So COVID-19 lies little above influenza, but way below the highly infectious disease like measles. So one COVID infected person can transmit it to anywhere like 2 to 3 other people. And even the fatality rate with SARS-CoV-2 is low compared to the other infectious diseases on the graph. So who's most at risk? Elderly who are more than 65 years of age because their immune system is weak. Those residing in long-term care facilities or nursing homes because of their comorbidities and also because of the living conditions. Those with underlying health conditions are more at risk to develop illness requiring hospitalization. So what are the comorbidities which make these people more susceptible to COVID-19? It's hypertension, respiratory conditions like asthma, mostly moderate to severe asthma, not the mild asthma, and COPDs, diabetes, cardiovascular disease, immune compromising conditions like if a person is on, he's suffering from cancer, is on anti-cancer drugs. Any age with severe obesity, we will look into this parameter in more detail because this has been the #1 on the chart across all the age groups. Then pregnant women should be monitored. So what they have categorized, currently CDC has categorized pregnant women at high risk, but we don't have any clear data on the vertical transmission from pregnant mother to the baby. But since this is a high risk condition, so they have categorized it in high risk category for COVID-19. So what is the burden of this disease on hospitalization rates? So if you look at this triangle, which is actually a pyramid, so if you see the maximum cases are mostly mild and moderate. There is a small percentage of cases that requires hospitalization, and of that, a small number of cases, so case fatality rate is also low for this novel virus. If you look on the left-hand side, the table shows you the hospitalization rate as per the age. So if you look, as the age advances, the hospitalization rate, the risk for hospitalization also increases. So if you look at the top line, which is the pediatric population, the top two, the hospitalization is as low as 0 in 0 to 9 years of age. And in 10 to 19, it's only 0.04%. But if you look at the elderly population, like 70 and above, it's as high as 18%. Age advances, the person is at higher risk of hospitalization with COVID-19. And similarly, even for mortality rate, the risk increases with advancing age. So for pediatric age group, it's very low. It's almost 0.0026%, versus if you look at the elderly population, it's as high as 13%. So when they sub-analyzed the death rates based on the comorbidities and also the gender, and the top comorbidity in these people who for the mortality rate was cardiovascular disease as high as 13%, followed by diabetes 9%, and chronic respiratory diseases including severe asthma was 8%, and other were hypertension, cancer. And when you look at the sex, male were more susceptible to this infection, and also the mortality rate was higher in male, because one thing which we see for in comorbidities is male are at higher risk of comorbidities as well. So that might be directly proportional to why we are seeing higher death rates in male compared to the females. So for the clinical characteristics of COVID-19, the top 3 signs and symptoms that were seen in the most cases were fever, followed by cough and shortness of breath or dyspnea. So fever was seen in pretty much 83 to 99% of all the cases, and coughing was seen in 59 to 82% of cases, followed by shortness of breath in approximately 40% of cases. So as I mentioned, the incubation period was anywhere from 2 to 14 days. So some patients showed signs and symptoms the very next day of contact, and some of them, they didn't have signs and symptoms up till 14 days, but they were still, they were asymptomatic, but later after 14 days, they started with either fever, cough, or shortness of breath. So just some key points about this disease. So as I mentioned, the hospitalization rate on an average was 4.6 per 100,000 population. ICU admission was 6%. So as age advances, there was higher rate of severe symptoms. We don't know exactly how much is the percentage of asymptomatic patients, and that is the problem why we are not able to, like in the contact tracing, there are some missed statistics. And median time to recovery from the development of symptoms is 32 days, so just a little above over a month. And the interesting fact which was seen in this disease is that even after the resolution of symptoms, so you are completely symptom-free, you're not infectious, but still viral RNA shedding was seen in in the body fluids. But these patients were completely non-infectious. So median time to development of some of these severe disease like to dyspnea was 5 to 8 days. Acute respiratory distress syndrome was 8 to 12 days, and ICU admission was somewhere around 10 to 12 days from the starting of those symptoms. So in addition to fever, cough, and shortness of breath, there were other signs and symptoms that were also seen in these patients. Mostly it was body ache, like we see in other respiratory infections like flu, headache. One specific symptoms of were seen, especially in pediatric population, was GI symptoms like diarrhea, abdominal pain. Sore throat was seen in a very small number of patients, not very evident. Then runny nose or throat pain was also seen in some patients. So since we do not have any treatment strategy, and also no vaccine is available currently for COVID-19, so what CDC has guided just to mitigate the efforts of SARS-CoV-2 was general washing hands as often as you can, avoid close contact, that is social distancing, use of face mask, then clean and disinfect the frequent touch surfaces just to avoid the fomite transmission, and stay at home order, which we already have gone through. So now this is the basics. Now I'll present something that CDC has specifically updated, and they have some new guidance and also some new information about the epidemiology and the transmission of this infection, which they presented last month during their meeting. So as I mentioned earlier, the incubation period is approximately, it's 5 days. But what is interesting about SARS-CoV-2 is that the serial interval, that is the transmission from one patient to other patient, is very less. So even before a patient starts seeing the signs and symptoms of COVID-19 disease, he has already transmitted that infection to other people. So that is, I think that is the reason why we see so many cases, and it's so difficult to contain, because the patient, before even developing the symptoms, he's infectious. So what are the transmitters? So which body fluids we have isolated the virus, and also they can transmit the information. So mostly it is respiratory. So the green rows that shows that the virus has been detected in the body fluid, and also they are transmitting the infection. So it's the nasopharyngeal, oropharyngeal, and also the sputum. So mostly the respiratory pathway. And coming to the stool, it has been detected in the stool, but it's not being transmitted by that. So there's no transmission through the fecal oral route right now. And then urine, body, blood or serum, amniotic fluid, umbilical cord, none of these have been, the virus has been isolated, neither are observed as a mode of transmission. Interestingly, there were 2 cases where they isolated the virus in the semen, but it was during the peak of the infectious disease, but later it was not seen or isolated, and there was no sexual transmission seen. So this is what I was talking about in terms of droplet transmission and aerosol transmission. So if you look on the left-hand side, it's droplet because they are heavier, so it's more restricted. It's only 6 feet or 2 meters of transmission, but aerosols, they can travel up to a few meters. So even if like you are few meters away from the person who is not wearing a mask and sneezed or coughed, so it can travel to quite some distance, but luckily it's not as infectious as the droplet infection. So we have seen the list of the most common signs and symptoms, but there are cases who didn't have a specific set of signs and symptoms, and they had some non-specific signs and symptoms like loss of taste and loss of smell. So there were almost like many cases, very prominent cases, where they just presented to their primary care physician with loss of smell and loss of taste. And those primary care physicians, when they tested them for COVID-19, they were positive. So for adult population, especially, loss of smell and loss of taste has also been identified as one of the signs and symptoms for COVID-19. Most people will recover spontaneously with supportive care, and some people who do not, maybe because of the underlying conditions or their lower immune capacity, typical complications that they developed were pneumonia, respiratory failure, multi-organ system failure, and even death. So this is an interesting study that was done in hospitalized patients across 14 states to see what was the most reported underlying condition. And in adult population, the most commonly reported condition was hypertension. So 56% of the patients had hypertension followed by obesity. So their BMI was higher than 35, and they've seen that they are at higher risk of COVID-19. Metabolic diseases like including diabetes, 42% of patients reported this, and cardiovascular diseases almost 33%. So higher on the chart, the list was hypertension followed by obesity. So if you look at some race and ethnic predisposition, it was seen that the hospitalization rates were 5.5 times higher in non-Hispanic American Indian or Alaskan Native compared to the non-Hispanic white on the extreme right side, followed by 4.5 times higher risk in non-Hispanic Black, and then 4 times higher risk in Hispanics or Latino compared to the non-Hispanic whites. And that's the reason I think they are more emphasizing towards some more precautions and more prevention in this specific race and ethnicity who are predisposed to COVID-19. So this is an interesting data where they have looked for co-infections, especially with influenza season like very soon we will enter the influenza season. So this was data from this year, early this year, where when in China, where this outbreak happened, there was always also influenza that was circulating. So they have this hospital where they had many patients with co-infection. So they tried to categorize those patients to see which strain of influenza was circulating more with SARS-CoV-2. And what they have seen is almost 50% of the patients had co-infection with influenza A, followed by just SARS-CoV-2, and a very small portion of population were having influenza B. But what is interesting here is if you look at the right-hand side, the graph shows you the mortality rate. And though the co-infection with influenza B is very low, but the mortality rate is so high. It's almost 30.4%. And that, I think we have to be very careful with influenza season right around the corner. And added this slide is just to emphasize on the fact that last year, the influenza season started with influenza B. So for the first half of the influenza season, it was all influenza B, followed by influenza A. And why this is important, just going back to my previous slide, is if you look at the co-infections with influenza B and the mortality rate, though it's a small portion, but the mortality rate is very high. And that is why this year influenza vaccination is very important for everybody. So this is the the statistics for mortality reporting. And if you look at this peak, this was after the COVID-19 reporting started. So for the mortality rate, if you look at the black line, that is the epidemic threshold. Anything above that, we call it like that we are still in the epidemic phase. So if you look at the current situation, we are at 7.1%, which is also above the epidemic rate. So unless and until this graph, the red line, comes below the epidemic threshold, we are still at higher risk of this like mortality rate with COVID-19. So talking about children, epidemiology in children and how it is different from the adult population. So this is just side-by-side comparison of the severity of COVID-19 infection in adults versus the pediatric age group. So on the left-hand side, if you look at the adult population, most of the cases, almost 81% cases are mild, followed by severe cases, which accounts to almost 14%. And then you have critical population around 5%. Versus if you look at the pediatric population, most of the cases, almost 85% cases are mild to moderate. A very small portion are severe and critical. But what is interesting is if you look at the asymptomatic population, it is higher in children, especially like it's almost 13%. And that is where they were considering pediatric patients as transmitters of this infection, though there was low incidence in this population. They were thinking that they are more transmitters. Then similar data which we had looked for the adult population. Here we have analyzed the pediatric population to see what was the underlying medical conditions for children and why they were hospitalized. So here, the top on the chart was obesity. Almost 38% of this pediatric population who were admitted for hospitalized for COVID-19, they were obese, followed by with some respiratory, like moderate to severe asthma, followed by some neurological diseases. So top on the chart is obesity. So what is different about pediatric population? So they might not present with specific signs and symptoms like fever, cough. Many children, they presented with very non-specific symptoms, like they just complained about abdominal pain or some diarrhea, not feeling well, nausea. And when they tested them, they were positive. So, and most of them, they even didn't have any evident signs and symptoms, and they were asymptomatic. As we saw in the previous chart, almost 13% were asymptomatic. But the evolving data, one thing is like, it's very reassuring because what they have seen in the follow-up, though the kids are getting infected with COVID-19, but they are not transmitting the infection, because in some areas, also in Texas, there has been a study where they looked at 40 children, and then they followed them after they were tested positive. And over a period of time, when they followed them for a period of time, none of their family members or caretakers or their contacts were tested positive for COVID-19. So, which is very reassuring with schools reopening now. So this was a very interesting syndrome which was observed. It was first observed in Europe, where kids were they presented to their primary care physicians and pediatrician with something similar to Kawasaki's disease, which is like an autoimmune infection and post-inflammatory autoimmune disease. And we don't know the exact cause. It could be post-viral. So this, the signs and symptoms were very similar to Kawasaki's disease. Like the patient, the kid presented with persistent fever, abdominal pain, and a rash anywhere on their body. So 52% of these children had a rash. And then they also saw cardiac involvement, and which was also the leading cause of death in these severe cases. So on May 14, because of growing cases of multi-system inflammatory syndrome, CDC has set a definition for this syndrome. So the patient should have one from each category to say that the kid has MISC. So fever more than 38 degrees centigrade, that is 100.4. Laboratory evidence of inflammation, so they should have increase in erythrocyte sedimentation rate, C-reactant protein, and all the inflammatory conditions. Evidence of clinically severe hospitalized illness with at least 2 organ involvement. Either it could be heart, kidneys, lungs, or any blood work, or GI symptoms, or skin, like I mentioned, rash, or any neurological symptoms. And then one of the following testing, like either the kid should be positive PCR, positive antibody, and if the kid is negative for both PCR and antibody, he should be, at least there should be an identified COVID exposure within the 4-week interval prior to the onset of symptoms. This is an ongoing study for MISC syndrome. It's called as the Overcoming COVID-19 study that has been initiated and coordinated by Boston Children's Hospital. So in this, 213 kids have been enrolled right now from 26 states, and most of the cases have cardiac involvement. So they are mostly male, 63% were male, and they were all previously healthy, except one thing which was evident is obesity. So 73% of these pediatric cases were obese, and median age was 8.4. The youngest were anywhere from less than 5 years, was almost 33, but mostly they were between the age of 5 to 21 years. So because of the COVID-19 and the disruption in the primary care for the pediatric age group, especially because we are more worried about infectious diseases, especially measles and pertussis in this population. If you look at the yellow line, this slide shows you the outpatient medical care. If you look at the yellow line, that's the outpatient medical care. And as soon as emergency was declared in March, you see a dramatic drop in the outpatient care and also the vaccination rates of pediatrics. It is getting better with a lot of other, like the curbside and the drive-through clinics where they're trying to immunize the patients. But if you look at some of the rates, like I was looking at the Arkansas, Oklahoma, and this territory. So for DTaP, it's almost we are at minus 43% right now. And for meningococcal vaccine, MenACWI, we are almost like minus 50%. So there is a huge catch up to do. And there is I think we are at now, the population is at higher risk for other infectious diseases. So it's we have to encourage the parents and also the patients to go and get vaccinated for other infectious diseases where vaccines are available. So if you look at the chart, the pediatric was the hardest his specialty. So there was 62% drop in the outpatient visits. This was an April data. It's getting better, but still there's a long way to go. If you look at, this is the VFC order data where they looked at the non-influenza vaccine orders. If you, in comparing, so the blue line is for 2019 versus 2020. If you look at the extreme right, you see that it has dropped to almost 50% of what was ordered in 2019. And if you look at measles containing vaccine, it has dropped further. If you look at 2009, and if you compare it with 2020, there is a dramatic drop in the VFC orders. So CDC has provided some interim guidance for immunization services. So they have encouraged everybody to get their kids vaccinated, especially because in summer they were not able to go for their well visits, do their catch up. And now with schools reopening and kids, most of them, they want to go back to school. So I think this is more important. Initially during the lockdown, even then CDC was encouraging all the infants less than 24 months to get vaccinated, especially to prevent any measles outbreak. So for VFC program, I think now more kids will be eligible for that program, because there will be not many parents have lost their jobs, and also they don't have insurance that covers, but they will be eligible. Probably we might have to encourage the parents to go and register and see if whoever is enrolled in the program, they can get free vaccines through the VFC program. This slide shows you just the general resources for the parents, just to encourage them to get vaccinated, what all precautions and preventions the primary care physicians or the pediatricians are taking to make sure that their clinics are safe for the parents, they can go back and get vaccinated, and why it is very important. So they have come up with all the resources, which is available on the CDC website, and we can share with the parents and caregivers. And for the school, this is the back to school vaccine, for the back to school vaccine clinics. I think this is important, especially the 4 to 6 year age group and the 11 to 12, which has been highlighted in the chart, because that is the age where they get 4 to 6, especially because they get their MMR booster. And measles, as you saw, it's high on the chart for infectious disease and also for mortality. Like I just want to reiterate that one measles patient can transmit it to almost like 12 to 15. So it's highly infectious, and that's the reason that age group is very important and critical right now. And influenza, with influenza season approaching, so this year they are starting to vaccinate early. So most of the clinics, I'm sure they already have their vaccines. And we have to encourage, because as we saw the data with co-infection, it's like influenza B. It's like what happened last season, mostly influenza B. Then it's going to be very severe infection with SARS-CoV-2 and influenza circulating together. So we should encourage parents and patients to get their kids vaccinated, also themselves, because it's all like transmitting. It also is an infectious disease. So we want to make sure that everybody is vaccinated, especially the high risk groups, which I mentioned, like it has a specific predisposition to race, ethnicity. So African Americans, Hispanic communities, also kids with, also patients with comorbidities, obesity, hypertension, cardiovascular disease. They should get vaccinated early in the season so that they don't see the co-infections. And yeah, it's very important this season, especially for influenza vaccination. So to conclude, as we have seen, COVID-19, it's causing like many cases, so many million of cases. And the challenge is right now is asymptomatic patients, and we don't know how much they are transmitting. and it's very difficult in terms of contact tracing. So for now, the best way to prevent the transmission and the limit the disease is the non-pharmaceutical interventions like hand washing, using the face masks, and social distancing right now. So also catch-up vaccination, as I mentioned earlier, it's very important with the back to school and influenza vaccination in summer and fall to prevent any severe co-infections with influenza and SARS-CoV-2. Also, the healthcare system for now, they are overwhelmed. If you have more cases with influenza and SARS-CoV-2, it will be very devastating going forward. And this is just a summary, and there are a lot of resources on CDC website where we can go and check for more information. And just want to share some updates from CDC with the back to school. They have just come up with these signs and symptoms, especially for parents and teachers and school nurses, to look for some of the specific signs and symptoms where we have to refer the kid or contact the kid's primary care physician or the nurse. So for children, it's majorly any fever, abdominal pain, vomiting, diarrhea, if they complain of neck pain, any rash on their body, and bloodshot eyes if they have flushing or red eyes, if they are feeling extra tired, like unusual tiredness, or the kid is not very active, then we have to definitely send the kid to their primary care physician. And then they have also categorized some emergency signs of the MIS-C syndrome. If the child complains of trouble breathing, pain or pressure in the chest that doesn't go away, any new confusion, if the child is not well oriented, he's not able to say his name, his parents' name, or he's not able to orient to the day, the place, or person, any inability to wake or stay awake, if the kid is very drowsy, and bluish lips or face, if you see any bluish discoloration, definitely that is a emergency sign that his blood oxygen level has dropped to a very low level. And then severe abdominal pain. So mild abdominal pain or anything related to GI, especially in pediatric population, is definitely alarming sign. And then they have also put together some signs and symptoms for adults. And this is a very nice tool, a self-checker tool, where the adults, we can go there, and if you have any signs and symptoms, you can just put in there, and then it will tell you if you should go and see you or you should get some medical care. So pretty much these are all like what we have seen in that list: fever, chills, cough, dyspnea, fatigue, muscle aches, headache. One specific thing is new loss of taste or smell. If you see any change in your taste or smell, definitely you should go and see your primary care physician. Headache, I mentioned, I'm sorry. So congestion or runny nose, nausea or vomiting, or diarrhea. So these are some of the signs and symptoms for adults where we should go and definitely get ourselves tested. And then even for adults, they have added some emergency warning signs like trouble breathing, pain or pressure in the chest, like for pediatric, new confusion, inability to wake or stay awake, and bluish lips or face. So these are some of the signs and symptoms where these are emergencies. So we have to definitely rush them to the ER or the physician. So this is pretty much about COVID and some of the updates which are very recent. So CDC has updated it, I think last week, which should be, especially with kids going back to school and everything, people trying to get to normal. So, and that's all from my end, and I'll be happy to take any questions you may have.
Thank you, Dr. Yaganti. There was a question about, can you define children's age? Is it 18 and under, or there's some talk about children ages 10 and up? Can you clarify when you talk about children and symptoms?
So for children, they have right now categorized 18 and under. So anyone, like they have said, infants, children, and then adolescents. So anybody less than 18 years of age, they come into that category where you have looked for the signs and symptoms.
Now, I have some other private questions in the chat, but feel free to unmute or post in the chat any questions that y'all have. One of the questions was, previous infectious disease doctor recommended masks and face coverings. Is that something that the CDC is still recommending for face coverings and mask, or is mask sufficient?
So CDC says that it's, so you're talking about the shield, which they are, so face covering in the sense they are talking about the shields, which they are supposed to wear. So for in general use, what they are saying is mask and social distancing is enough, because for shields, it's mostly like when it's the aerosols, but we don't know how infectious they are. But for pediatric population, especially because they will touch their eyes and they are not very conscious about that. So some infectious disease physicians say that they should be wearing the shields as well, and they don't cover their mouth, and someone might but just cough or sneeze. But CDC recommends face masks, social distancing, and hand wash.
Another question is, how long does the influenza vaccine last on average, and what's the need to seek out this vaccine before school starts?
So influenza vaccine, the data shows that it pretty much covers your the whole season, influenza. There is a little, some papers and some studies, they show that there is a little waning immunity at the end of the season, but it is not to that level where you get infected or you have to take another dose. Right now, there is no data where they say that you have to get another dose. So one vaccine will cover pretty much the whole influenza season. And right now, CDC says that you can get vaccinated right from September. So September, you can get your vaccine, so that also because SARS-CoV-2, it's already circulating, and you will take anywhere from 3 to 4 weeks to mount the immune response to the flu vaccine. Get in September, usually the influenza season, it starts from October. So if you get it in September, your immune system will be ready by October.
Thank you. Another question is it recommended to get the COVID-19 testing for if you're starting to show symptoms for tracking purposes, or is it better to stay home and recover independently if possible?
So for the mild symptoms, if you are like, you have very mild symptom and you got tested, isolation is the best way. But you tested, definitely that will be reported. They will report it. But if you are seeing some signs and symptoms and you're not sure, definitely you should get tested and see your, at least by telemedicine, you should make sure, because sometimes some patients might have just sore throat, and that's not alarming, but you should definitely check with your primary care physician if you have fever, cough, at least by telehealth, so that if they feel that it is something related to COVID, they can ask you to come in and get you tested. But isolation, definitely, if you start the signs and symptoms, just so that you are not transmitting it to other people, isolation is always the best first-hand thing you should do.
Thank you. Let's see. Oh, can you talk more about asymptomatic symptoms or non-symptoms in students and adults? What to look for? Is it highly transferable?
So asymptomatic patients, they are completely normal. We don't know. So that's one thing, that's the reason we are not able to contact, like trace. But the good part is, for now, they are not like transmitting the infection. They are not highly infectious. So if at school, especially at school, even the kids are asymptomatic, but they are wearing masks, they are doing hand washing, it's very unlikely that they will transmit the infection, because it has to be droplet, like they have to cough or sneeze directly on the other person. Only then it will be transmitted. Even then, to what extent it is infectious, it's not very clear. And recent data is very reassuring that it's not very infectious. So if they are following the basic non-pharmaceutical interventions like wearing masks, hand washing, and maintaining a distance, So they should be fine. They won't transmit it to other kids or other teachers.
Another question that we've been asked a lot is it safe to use mask breaks in the classroom for students throughout the day, especially while eating in a common area, things like that?
No, eating, and also there is a lot of data that shows that especially for kids under the age of 5 and all, they are not recommending masks either. But like hand washing and all is like, because luckily this disease is not the incidence in pediatric population is not high. Could be there are a lot of hypotheses going on, like they are recently vaccinated with MMR, or their immune system, they recently were exposed to other human coronaviruses. So these are all like different hypotheses. We don't know why exactly the incidence is so low, and but not just like having them like while eating or anything. It's not important to have masks.
Thank you. Other questions, feel free to unmute and ask or write them in the chat. Sometimes it takes a little bit to type them.
Yeah, that's okay. Yeah, so there's a lot of information and it's evolving. So CDC has another meeting this month. We will get more updates, and if I have some updates, I'll definitely forward it to Dustin so that he can circulate further if they have some guidance. But I think following the basic things would help, especially the mask, or just the mask, hand washing, and social distancing should be good enough to at least prevent transmission.
Another question was asked, can you clarify again when the most contagious period is for COVID-19? Is it before symptoms start showing, or is it after?
So in some cases where, so as I mentioned, the incubation period is from 2 days to 14 days. So the median is when it peaks. In most of the cases, it was like the 5th day where they saw that, okay, it's highly infectious. But this is varying, especially with the severe cases who get hospitalized with some comorbidities and underlying infection. They were infectious very early in that. But luckily, because in a way they showed signs and symptoms, so they were isolated. But so right from you say that you know that you have come into contact with someone, if you isolate yourself and follow the basic distancing and all, it's good that you don't transmit it to other people. But mild cases and moderate cases, they are not very highly infectious. And if they are just, if you have a runny nose, you have some cough, you have body ache, and you start isolating yourself, keep yourself away from other family members or your workplace, and follow the basic rules and guidance, it's not that like the transmission rate is not that high. So for severe cases, I would say that is where you see very high transmission, because the viral load is also very high in them. And it is usually in the early part of the disease when the symptoms just start. And so sometimes you don't even realize that these are the symptoms of COVID-19. And if you are just going and talking to people, definitely you will be spreading the disease.
If we show signs of symptoms of the flu or COVID-19, are there combined tests that will test for both this spring or this fall?
Yes. So luckily, FDA approved a test, a rapid test that will be available in all the clinics, hopefully before the season starts, where this is a one test where it tests for COVID, influenza, and few other respiratory illness, which is a good thing now, because that was the challenge initially. So they categorized COVID into COVID-like illness, and then we had like influenza-like illness. But then it was hard test, because the COVID results, it initially took like a week or so to get the results back. And it was a huge dilemma on healthcare system, like how do we categorize them? And they were just isolating everybody, and we didn't know if it was ILI, it was CLI. But with this rapid test approval, now as soon as you go there, they can test you, they can say, oh, it's ILI, influenza-like illness, so you can take they can treat you for that. But if it's COVID, they can just treat you for COVID. So that is one good thing that's available and positive thing for this fall.
Thank you. Another question was, does the amount of exposure affect the severity or likelihood of infection?
Yes. So it's seen in some contact tracing that if the person is severe infection and his viral load is very high, and if you are a direct contact, like exposed to the droplet and all, then the infection load will be higher. But then the amount of signs and symptoms, like how much signs and symptoms you show, would also depend on your immune system. So if you are healthy with no underlying conditions and your immune system is good, then you might not have severe infection and just have like mild signs and symptoms of COVID-19 and recover very quickly.
I think I've answered all the questions I see in the chat. Thank you, Dr. Yaganti. We appreciate all your information today. Are there any last minute questions? Lots of very helpful information.
Thank you. And if you have any questions and concerns about, I'll just put it on my slide where you can just send an email and you can, I'll be happy to answer. So I hope you can see my email ID here, and please feel free to just send any questions or concerns, or if you need any updates or like you're not able to find answers. And so I'll be happy to answer. Even for influenza, I think if you go to the CDC website, I'll be happy to share the link. They have put a really nice frequently document. They have just updated it last week, like how do I say this is influenza? What should I do? When should I get the vaccine? Like all the questions you have, they have put a nice document with all the frequently asked questions. So I think we don't have vaccine for COVID, but we definitely have for influenza. I think at least we should avoid any co-infections, because that will be the major thing which will cause a severe infection this fall.
Well, thank you again for taking your time to speak with us today. And I know most of us or all of us are muted, so we're quietly giving you an applause, but thank you very much for your time. And we look forward to hearing from you again in the future.
Thank you. Thank you so much for this opportunity. And thank you so much for all your efforts to make, keep the kids safe and still go back to school and help them with the system, because it's really, I know these are challenging times and it's very overwhelming with this novel virus where we don't know what we are supposed to do. But thank you so much for all you're doing for the kids. So thank you and appreciate your time.